So this is a familiar measure to all of you, and I don't think we need to spend so much time talking about it. We get quite a lot of pushback in an NNAP world that this is the wrong measure. This is an inappropriate measure, and that if it's not written down, then it's not done anyway. I'm easy with that. If people think it's not important in their units, then I'm fine with that. But I know from our own unit experience that actually this measure is meaningful, and there are often times when we think we've spoken to people when we haven't. So I found this useful in our world, and I know others have found the same thing. We know it varies. I'm going to skip over that. From a meeting 2 years ago, we have developed an NNAP measure, trying to measure parental partnership in care around parental attendance or presence on a consultant ward round. Our parent representatives on the board felt strongly, and we were strongly supportive of them, that this was a good thing to try and measure. We know that parents' representatives, and Bliss in particular, think that parental participation in ward rounds is an important thing. Not all clinicians agree. There are clinicians who are strongly opposed to this, and clearly the audit measure won't be useful to them. Nonetheless, we think this is worth measuring. As you know, the data's not out. I can tell you that for Bradford, we had 498 admissions, and in only 60% of them can we show that a parent was present at a ward round at any time during the admission. So I think there's an opportunity to do it even better there. Those colleagues from Bradford are here. But the main thing I wanted to touch on connects nicely with what Sam's been telling us, which is about access to care. We know that people sometimes have to travel inappropriately for neonatal care, and that feels like a thing that we as a community ought to address. We had a care in networks measure in NNAP, as many of you will remember. So we abandoned that measure for technical reasons. We couldn't make it work, and it seemed inappropriate to publish data that wasn't really, it was a little bit potential, it had potential to be misleading readers. But the measure was actually based around a completely arbitrary target, which is that neonatal networks should go after 95% of their own patients. And it makes the assumption that transfer out of network is necessarily intrinsically a bad thing. Whereas actually from a parental travel perspective and from a baby health perspective, it might not be an inappropriate thing at all. So, that measure's gone. We've been considering using parental travel time, derived from Mike's work, from Michael Allen's work, as a metric of access to care. And I want to show you something that we've been thinking about in order to get your feedback, and I appreciate that probably will be on a one-to-one basis, but you can ask questions if there's time. So in order to explain that, I've brought a slab of the frozen north with me to the south. I want you to imagine that there's a baby born here, where this big fat red circle is. And a baby's going to be born. You're the mother. Some of us will find that easier to imagine than others. You're the mother. You're about to have a baby at 26 weeks gestation, so meeting the criteria for nursing in a NICU. There are 2 NICUs relatively nearby. And there are other NICUs are also available, let's say. So from Calderdale, where this notional woman is delivering it, it's 29 minutes to the nearest NICU and 35 minutes to the second nearest NICU. But if the woman ends up having her baby in Sheffield, that's 66 minutes away, and if she ends up in Liverpool, fine place though it is, that's 78 minutes from Calderdale. These are all highly plausible. So within the context of this proposed standard, we would say that either of those is acceptable, but that those are unacceptable, and we draw the dividing line on the basis of the travel time from parental residence to the NICU of care, or to the unit of care, and if it's half an hour longer than the nearest appropriate unit, so in this case that would be this one, 29 minutes, so that's more than half an hour longer, and so that's a failure. Hopefully that makes sense. You're all kind of looking like you get that, which I've struggled to explain this previously. You can subject every neonatal unit admission in the country to this test. Well, in England currently. We can subject every admission to this test, and we've set this threshold as 30 minutes on an arbitrary basis. So 30 minutes in excess of the travel time to the nearest appropriate unit. And we've done an analysis of this for all babies who receive intensive or high dependency care. And we proposed 3 measures. The proportion of admissions with any long travel time. So we need to think about, some neonatal networks are very geographically dispersed, the Peninsula being a good example. And then the proportion of admissions with an excessive travel time. And finally, the proportion of care days where the travel time is apparently excessive. And the idea is to compare neonatal networks and to attribute every baby to a neonatal network on the network of final discharge, on the basis that if you're discharged within a given network, that's probably where you're going home. You're going home to an address within that network. And the question really is, we can produce outputs about this, but are they utilisable? And the agent of change here is neonatal networks, isn't it? So this is a graph describing 13 neonatal networks, and I think you can see that there's a couple of neonatal networks, that's one, and that's another example, that have quite a high proportion, more than 10% of their families travelling for more than 30 minutes. So if we then consider the nearest appropriate unit, these are the same networks in the same order, you can see that the network before, this network here, apologies, starts to look much more in the pack. And when you know the identity of that network, that makes sense, because they're geographically dispersed. This neonatal network, more than 1 in 20 of their babies are travelling more than half an hour past the distance that would be to the nearest appropriate unit. So I think there's a degree of variation there. I'll skip over that, that's the time. So we're talking about 30,000 admissions, and it's admissions, not babies. And of those, 2,663 have a long travel time, more than 30 minutes. But in a significant number of those who have a long travel time, it's actually inappropriately long, excessive. So it feels like that there might be a thing, and regardless of the level of between network variation, and there does seem to be some, I think it's striking that a lot of women and families are having to travel quite long distances. So it may be that networks are not optimally configured. I think Mike probably convinced us of that earlier. The question is whether these data will be useful to networks. So I'll go back over there. Does anyone have a question for Dr. Oddie? Or Sam, more importantly?
Thank you for presenting this excellent data. I guess we're trying to use the travel distance as a proxy to family experience. It's not necessarily that always the closer unit offers the better family experience, because a unit that is a few miles further but provides accommodation to the family and has free parking might be providing better family experience. I know it's really difficult to figure that all in. I would like your comments on that.
Yeah, I absolutely accept that some units offer a better family experience than others. I'm not sure how an NNAP could measure those much as we've discussed, much as we'd like to do that. I guess if you consider that the agents of change are neonatal networks, then I suspect, and the networks are represented in this meeting, they might want to speak to that, but I suspect they're all trying to provide as good a service and probably as equal a service as possible within the context of their networks. But it's a fair point. Whether that means this isn't useful or not is really the question.
What about the possibility of relatively stable babies in NICU, which are full, being transferred not to their native place, but local neonatal units to create more space in tertiary units for the babies not to be transferred extremely long distances? Has there been any talk regarding that?
So we certainly haven't done anything about that within the proposed measure. I guess if you were a parent and designing the system from scratch, you probably wouldn't, or a network, you probably wouldn't want to design that in as your ideal solution to managing capacity. Would be my take on that, but it's clearly something that pragmatically people sometimes do. Martin, no, it's good. Sorry, you're not my turn. Bright light in my eyes. So we've got Colin and then Sajid.
Sam, with centralisation of some services, you're going to, into certain networks, you're going to have a focus of parents who have to travel longer distances. Any thoughts on how that might be considered when we think about surgery or ECMO or cardiac services?
That's fantastic. Thank you. Great steer, Colin. So surgery, ECMO, and cardiac are all out of this analysis. Thank you for reminding me. He knew, actually. But what a fine person you are. Can you possibly sprint over there? No, he's I've answered the question already, but we've got a colleague here.
Oh, sorry.
Rachel, there was one just there.
I hear what the aim of the measure, and that makes sense, but it's going to depend on capacity, and moving that capacity around might destabilise NICUs as well, so I'm not sure what we would do with it when we get it.
Well, I guess that's the key question, and it's probably, I mean, it's not one that I accept that we could definitively answer in this context. What I'm hoping is that neonatal networks will want to engage in looking at this data. I think it's quite surprising how many families end up moving really quite significant distances. I knew this was an issue. It was surprised to me the extent to which it's true. The question really is, do networks think this is a useful thing to report on once or regularly? And I think we need to take that outside of the room. But I wanted to show all of you and get the clinician and other colleague feedback in this forum too. Kate.
Sam, thank you. I'd like to preface my comment with a statement that I think not all networks are equal. Not all networks operate in the same way. And my experience is only really of the network that my unit is within. But it's my observation that when a decision is made that a mummy carrying extremely preterm borderline viability babies, for example, is made, that there is not a network response to, oh dear, there's no cots in this network, it's going to have to move 2 networks further down south, up north, wherever that may be. And I think that as a community, as a network, I'm not clear that that decision is always taken collaboratively. It's my experience that it's generally taken along the lines of, no, sorry, we're full, no, sorry, we're full, no, sorry, Labour Ward hasn't got any beds, and it's no longer the network's business because there just isn't a cot declared within the network. And I think in that situation, this sort of information has the potential to be very valuable to networks because they could then look to see, well, how do we compare with other networks? Is everybody having this problem? If it is a problem, what can we do about it? The comment that somebody behind me made about moving a baby who's more stable, for example, is an absolutely obvious one. And I'm sure there are other solutions. We recently had a situation in the network that my service has just moved out of, where a known baby with a very serious problem was needing to be delivered in a special care baby unit, and was extremely ill. It was known it was going to need neonatal intensive care in a special care baby unit, and no cot was able to be found for this baby. So we raised this through our I raised this through our CDOT panel to ask the network, what is your collaborative response? What is our collaborative response to these very difficult decisions? Because I'm not clear that as a network we're taking them on board. So I think, in answer to your question, I believe that this sort of data may well be very valuable to networks.
Thank you very much, Kate. So where we're running out of time, Nina had a question, but she's done. So what I suggest we do is take some tea, if that would be okay.